All right, y'all. Whoa. 1 second. All right, cool. We got a case this morning. It's going to present to us by Nat. I don't think Jill's going to do very much. She looks like she's just kind of chilling. So Nat's going to present. It's a very comfortable. Yeah, that's true. Very comfortable chair. But Nat's going to present a case for TMAR of the week. So Nat, take it away.
Yeah, so we got a 74-year-old woman coming in. She's got a history of breast cancer, was resected, also finished a round of chemotherapy, well, all of her chemotherapy really. Also cervical cancer, had a hysterectomy, and then a variety of vasculopathic conditions, hypertension, hyperlipidemia, type 2 diabetes, had a history of coronary artery disease as well. Not really sure when that was diagnosed. And then a history of retinal vein occlusion at some point in the past. So she basically called EMS because she was showering and then she all of a sudden felt lightheaded and passed out in the shower. She kind of guided herself to the ground, but definitely lost consciousness.
Oh, and last question, any meds that she's
on? So her home medications, she's taking amlodipine 10, baby aspirin, Coreg 6.25, Plavix 75 milligrams, Crestor 10 milligrams, rosuvastatin, and then valsartan hydrochlorothiazide 320 and 12.5, and then as well as insulin for her diabetes.
All right, so I promised you I wouldn't do this to you, but we have a syncope case for this morning. But actually, we haven't really had a syncope case this year, so I think it's okay to do. All right. Any questions about, there we go. We got some questions in the chat. Has she ever passed out before? What happened then?
Yeah, so she actually, her symptoms started in February and March, actually, several weeks ago, or months ago. And would have episodes of dizziness and lightheadedness that would occur seemingly without trigger. It happened about once a week, she said.
How long ago was there cancer diagnosis treatment?
She finished her last round of Herceptin 1 year ago.
Did she have any prodromal symptoms like palpitations or sweating, warmth?
No prodrome.
Great question.
Showering.
Great question. Any recent change? Okay, here we go. Any prior syncopal episodes with exertion, at rest, or both?
No prior syncopal episodes of exertion, but she did tell us that she had a similar presentation in 2018 where she was also showering, got lightheaded, lost consciousness as well. The workup for all that was very unrevealing.
All right, and then what is she doing when she gets dizzy or lightheadedness?
Other than just standing up in the shower, not much. She wasn't going from a seated to standing position. She had been in a standing position.
Nice.
That's pretty much it. She was just doing normal showering activities, not like yoga or calisthenics or breathing exercises.
She ever passed out while sitting down? That's a question for me.
Not clear.
Not clear.
She had episodes of lightheadedness both while walking around and while in a seated position, I guess.
Okay.
If there's no real rhyme or reason to her sensation of lightheadedness and pre-syncope.
All right. Any recent changes to meds? Any new meds?
No recent changes to meds. No new medications.
These are all phenomenal questions. Any flushing? I think you said no flushing. Did you say anything about flushing?
It was unclear whether she was flushing or not. She didn't know. There was nobody else that witnessed the fall.
Okay. And then any prior neck surgeries?
I don't believe she had any prior neck surgeries.
All right. And then how long till she can regain consciousness? Does she know?
She doesn't know. But she didn't have, the water was running when it happened. She didn't drown or anything.
Okay.
She didn't have any hot water burns.
Do you think she takes her meds correctly?
Ooh, that's actually a good question. On my evaluation, she seemed to be at risk for incorrectly taking medications.
Okay.
But she said that she was taking all of her medications.
Okay. Was the room spinning at all?
No, she just said that she felt lightheaded. It was not like a room spinning sensation.
Okay. And then last question we have so far, was she injured by the event?
No, she did not have any lacerations or bruises on her head. She was able to sort of guide herself to the ground, and then she lost consciousness.
Okay. And then any chest pain then, or has she just ever had chest pain?
No chest pain during the event. She did have chest pain previously for her coronary artery disease, which triggered the workup, but that was not right now.
Okay. Do we have any more questions? Any more questions, concerns? Alvin is getting to the chase a little bit, maybe. Has she ever had a halter before?
So her previous workup for the prior episode of Syncope in 2018, they recommended a halter, but she never got it.
Okay. You said the episodes were mainly in the shower, right?
Well, they're mainly not really linked to anything.
Not really.
It just so happened that the last time she was admitted, I guess she wasn't admitted, but she was seen in an emergency department. She was also showering in it.
Okay. Okay, that's 2 showers. Happened twice in the shower.
Yes.
Any prior echo or carotid screen?
No.
No echo.
Well, I guess she did have an echo.
Okay.
No carotid screen for sure.
TTE. What did that show?
TTE basically showed. Let me see. Sorry. Just some aortic valve calcification, concentric remodeling, and 72% EF.
And when was that done?
That was done a year ago.
Okay, and then we kind of got to the hot shower thing, but it sounds like it does happen in showers, but not outside of showers.
It does happen outside of showers.
Yeah. Any LVH? I guess concentric remodeling, but any.
Yeah, there was some
LVH,
concentric
yeah.
remodeling. That was the last echo we had.
Okay. This is great because, the workup of syncope is history, and then more history. So I think you guys really hit almost every single thing here. That, the red flags for syncope. But I think we could probably do vitals. Any further questions before we move on? No? All right. So vitals.
So vitals in the ED. 142/84 was her blood pressure. Her heart rate was 74.
Okay.
Setting 100% on room air. BMI was 31.4.
And then any association with stress for her with the fainting, like I guess trying to get the neurocardiogenic, sounds like.
Yeah, no, there wasn't seemingly any like major association with stress.
All right. And then what do you guys, every single one of these patients, what do they need to do on a physical exam? What do you always need to do? Or there's a couple things, but. Yeah, orthostatics. So every patient with syncope needs to get orthostatics. Did you get orthostatics?
So she got 2 of the 3.
Okay.
Lying down, her blood pressure was 155/78.
Okay.
Sitting down, it was 142/84. Let me make sure that let me see if they recorded a standing. They may very well have. Standing was 157/84.
Okay. Okay, so not much change.
No.
So orthostatics were pretty much negative, but great question. Blood pressure taken in both arms.
Probably not.
Oh, and the heart rate as well. Did the heart rate jump up at all during the orthostatics?
The heart rate was 60 for lying down and 61 for sitting and then 74 for standing.
I think that doesn't quite reach it because there's I think it's usually best to go by 20. Yeah. All right. What else do we need and blood pressure taken in both arms?
I think it was just one arm.
Just one arm. What else do we need in every single one of these patients on a physical exam? There's one major bucket of syncope. It's not super common, but it's something you always have to rule out. Yeah, listen for murmurs, absolutely. So cardiac exam. Anything on there? The cardiac exam?
Oh, cardiac exam, sorry. No, not to my recollection. The cardiac exam was fairly benign. I didn't notice any murmur. There's regular rate rhythm.
Okay. All right. And then neuro exam. Exactly. So neuro exam, I mean, less than 10% of syncope is from a neurological cause. But you always need to do a neurological exam just to rule out things like, things that can happen is, subarachnoid hemorrhage, carotid dissection, vertebral basilar stroke can cause syncope. Uncommon, but, it's easy to do a neuro exam and you really don't have to go much further if the neuro exam is negative for any focal deficits. Did she have anything on neuro exam?
Neuro exam. She had a dysconjugate gaze, like a left third nerve palsy.
Is that chronic?
Yeah.
Okay.
That's from 2017. Full strength, full sensation. And then gait she had a slightly limping gait on the left.
Was that chronic?
Yeah.
Okay. So no acute changes.
No acute changes.
Okay. Neuro exam without any acute changes.
Yes.
All right. So what we're going to do is we're going to flip it a little bit. So we're going to put you in breakout rooms, but it's not going to be just this case. I'm going to give you all mini cases. So you're going to be in 3 different breakout rooms. So everyone do this case and do differential diagnosis and further workup. Let me see the breakout rooms real quick. So I'm gonna make 3 breakout rooms. So they'll be a little bit bigger. All right, so breakout room number 1, tell me what you wanna do on this case. And then also tell me what you wanna do on this case. So you're gonna get quick case number 1. Actually, I forgot to put this on a Google Doc. So if you guys just wanna take a picture with it on your phone real quick, And breakout room number 1 is going to be Anita, Chantel, Jesse, Sahaj. So take a quick picture of this and then tell me, what do you think this patient's cause of syncope is? And what do you think the patient's next step is? All right, let me know when you guys are good. Anita, you got a pick? You guys are good, moving on? All right, so, all right, this is quick case number 2. This is gonna be breakout room 2. This is gonna be Alvin, James Lee, Lauren Lally, Mario, Matt DeMeglo, and Stephen Montebianco. So, you know, I want to take a picture of this. These are all cases that either me or Navi have seen before. So these are all authentic cases, which is why they might be a little confusing. All right, so that is quick case 2. And then, where is it? Oh, this is quick case 3. So breakout room 3 is going to be Ashley, Candace, Ed, Seuss, Sam, and Travis. So this is your case. You want to take a quick picture of it, and let me know when you guys are ready, and I'll put you in the breakout room. So you're going to be answering the main case, but also your own quick case. You know, what's your differential and what's going to be your further workup. The quick cases are all authentic cases, and they're actually all a bit complex because I feel like we're later in the year. There might be some weird kind of stuff thrown in there, but more for you guys just have fun with, and then we'll go through the differential diagnosis of syncope. So everyone good? All good? All right. See you all in a little bit. All right, y'all. How about we get someone from breakout room 1? What did you think this case was? Am I muted? No, we're good. What did you think about the quick case? This was the lady I had actually on the floor.
Wait, are you asking group 1?
Yes, breakout group 1. That which is you're in that, Anita. If you want to talk.
Oh, okay. We were concerned with her history of COPD and sudden syncope for PE.
Ooh.
We thought maybe there was a little bit of, there's S waves in 1 and very small Q waves in 3 with some inverted T. And so we're wondering if there was a right heart string pattern. And wanted to do a bedside POCUS and also send her for CTA.
All right, bedside focus shows. Yeah, heart here. Uh-oh, what's going on with the RV? It's big. It's a big old RV. And CTA shows that. So this patient was on the floor, actually, and she was being treated for a COPD exacerbation. Then she told me, she's like, yeah, I just passed out when I was outside the hospital, like sudden onset. And then I got, really short of breath, and, she was pretty tacky on the admission as well. So even though she was in the hospital, we ended up sending her for a CTA, and the CTA did show that she had what looked to be a PE. And then she really had a submassive PE, and when she wasn't, massive PE needs to have hemodynamic changes with hypotension, but she did have a dilated RV. So she was treated with anticoagulation, discharge. PE is one of those things, when you're going through the different. So actually, let me just go through kind of my approach, or what your approach should be to a patient with syncope. So first thing is you want to rule out the other S's. So think about seizures, think about hypoglycemia, think about stroke. So syncope, seizure, sugar, stroke, that should be kind of on your differential for loss of consciousness. As we did in the beginning, all patients get a full H&P with a neuro exam, EKG, orthostatic. You should do labs, especially, hemorrhage can be a cause of syncope. Anything that causes shock-like state can be a cause of syncope, obviously. So you should really get basic labs on almost all people just to risk stratify. It's kind of up in the air whether you should get a troponin or a pro-BNP, but if you are suspicious for anything cardiac, these can be very helpful. Then it kind of goes into 2 buckets. Are you videotaping me? I'm getting videotaped here. Oh, wow. All right. The first bucket is the bucket with no red flags, and the initial workup suggests a clear etiology. And these are really either kind of 2 things, neurocardiogenic or orthostatic syncope. These are things that, you say, like typical neurocardiogenic, you have a young patient, they had a presentation, they start getting woozy, they have this kind of long prodrome, greater than 5 seconds. They try to catch themselves, they get weak, and then they pass out on the floor. Another one that can happen as well is patients may have really, really tight ties or like tight shirts actually pressed on their carotids, can actually cause neurally mediated syncope that way. If the history is totally consistent and it's a young patient without any red flags, you don't need to do a further workup. You can send that patient out of the hospital. If it's recurrent, you can consider a tilt table, but that is somewhat controversial, but MCSAP does say recurrent, consider a tilt table. The other one is going to be orthostatic, and this is really anything that decreases someone's blood pressure, right? So anything hypovolemia, medications that cause vasoplegia, and you'll prove this with doing orthostatics, and treatment is really conservative management. One that's I kind of put in here, maybe it's not the right, is postprandial syncope. I don't know if anyone's seen this before. I've actually seen it twice, even though it's not talked about a lot. But this is typically like an older patient. When you're older, you're not able, you're much more likely to syncopize. You have a bit more hardened arteries, so those arteries aren't really able to change their vasoconstriction very quickly. They have decreased cardiac output in response to, when they have decreased preload coming back to their heart, like things when they stand up and things. So, but this is like an old patient who eats a big meal, and then syncopizes right after a big meal. So this does happen, and then you just tell these people to eat some small meals. What we're really going to go into today is more syncope that either has a presence of red flags or an unclear etiology. And the first category that we're talking about here is vascular. So you just kind of need to consider these things because these are really emergent causes of syncope. So consider PE, consider aortic dissection, especially anyone who's coming in with syncope and other symptoms, right? Shortness of breath, syncope, and chest pain. You really need to consider getting a CTA. So that was our first case. Any other thoughts on just the like the overnight case? I think you're muted.
We talked about, I don't even remember what we talked about, honestly. We talked about like repeating, making sure we actually had like multiple good sets of orthostatic. Patients can be not always orthostatic and have to reproduce the actual symptoms during those vital signs. Getting obviously sorry if you guys already did this, EKG instead of lab.
What did the EKG show?
Yeah, that's a great question. So the EKG was might have had some AFib in it. It was a little bit like of a poor study, but overall it looked like sinus rhythm.
Okay, so kind of normal. All right, EKG, and then sorry, anything else you guys said? Repeating
Were there labs? Also, we said send her home. No, I'm just kidding.
Oh no, I mean, any labs are just normal. Labs are normal.
Yeah, labs are normal.
All right, so let's move on to case number 2. Oh, and this was just going over why there's this did have T. One of the big things you see on an EKG, I think whoever went over T waves, is these T waves inversions in V1 and V2. Just something to think about with repolarization abnormality, which can happen to a lot of different things, LVH, RVH, but just remember that V1 and V2 are kind of next to where the RV are. So if there's a repolarization abnormality in the RV, either due to damage, abnormalities in electrical conduction, RVH, things like that, you can get these strain pattern in V1 and V2. And a T-wave inversion in V1 and V2, other than tachycardia, is like the most common thing that you're going to see in a patient with a PA. Also V3. All right, cool. So that brings us to that. Let's do quick case number 2. Who wants to talk about this one? Yeah, Alvin, maybe?
I can talk about it.
Thank you.
So basically this guy is 39-year-old, coming with loss of consciousness, having facial abrasions, a bilateral shoulder dislocation. So first off, just thinking bilateral shoulder dislocation, my mind automatically goes to seizures. He also is somnolent, is ANO ×2 after this event, has some focal weakness, imaging's negative, and he frequently wakes up with tongue biting during sleep. So we thought this was most likely in our seizure category of things. Given the tongue biting, the shoulder dislocations, it seems like this happens frequently in the post-ictal state of being not quite at baseline. So next steps we'd probably get an EEG, just get some basic labs, and call Nat for neurology.
So great, perfect, and that's exactly what this was. This was a case Navi had in the hospital. The patient had a whole entire workup, CTA, CT of the brain, echocardiogram, telemetry, and everyone was like, "Oh, why did the patient syncopize?" But there's definitely some red flags for some neuro issues here, right? And actually, I didn't include this. It was bilateral posterior shoulder dislocation. Also, he hit himself when he fell as well. That's another red flag because that means that the patient didn't have a very long prodrome too. And like, it was kind of random, but he did wake up with his tongue biting during sleep. So this is actually was a patient who had seizures. So that's kind of our next bucket. And when to really think about neurologic causes of syncope. Really, the big things you think about here are stroke, subarachnoid, dissection, seizure. But you only do a stroke workup if the patient had focal defects. So that's kind of this is why we need to do a neuro exam on every single patient who has syncope. It's less than 10% of findings you're going to have neurologic syncope, but it's you need to do that workup, and you really need to think about it and rule it out. EEG, obviously, if you're concerned that the patient has a seizure, and this was his EEG. He had a tonic-clonic seizure with the hospital with EEG monitoring, and he was diagnosed with seizures and started on, actually, I don't know the rest of the story, but keep it on your differential. There's another thing, and this was a New England Journal of Medicine article of atonic seizures. So this patient had a tonic-clonic seizure, but there's also atonic seizures that can look a lot like syncope. People can regain their consciousness pretty quickly. This patient also, that somnolence right after was his post-ictal state. And then he did have some focal weakness in his arm. It's kind of tough because he also had shoulder dislocation, but he probably also had some Todd paralysis afterwards as well, which you can get sometimes with seizures. So perfect, great, keeping that on the differential. And then we got for our last case, we're almost out of time. What do we got for quick case number 3? Any thoughts on this one? And for that, someone's going.
Oh, we thought it's a young guy who was having palpitations and then suddenly passed out while he was wrestling. So we thought, it's very concerning for cardiogenic cause of syncope. 2 things we were thinking of is the EKG, possibly not 100%, but maybe some delta waves, or widening QRS. So we were thinking either WPW or HOCM. So we were gonna say get an echo and then, and then EKG monitoring of him.
Perfect. So yeah, that's absolutely the next steps for sure. And he got those. I'll go back to that. So I think you touched on the things that you looked out for, cardiogenic syncope, right? The big things that you're looking at. So if we kind of talked about neurocardiogenic, it's usually greater than a 5-second prodrome. One of the things that can really clue you into a cardiogenic syncope, especially in arrhythmia, is going to be less than 5 seconds. So if that patient is walking or they're just sitting there and they just suddenly without any prodrome pass out, that's very concerning that they just kind of went into an arrhythmia, and you need to do a further cardiac workup. Other things, and I think you guys really got to this, is the patient have any chest pain, palpitations as well. So any symptoms that localize to the heart. Patients who syncopize while sitting down is pretty concerning as well, because that makes it much less likely to be any of these more benign causes like neurocardiogenic and orthostatic. And you touched upon this, a lot of the mechanical causes of syncope can be during exercise. And the mechanical causes, the big ones you always think about are aortic stenosis, HOCM as well. And also, you get put into a sympathetic state with exercise as well. So arrhythmias may be more common. So your further workup, like you kind of said, for only less than 10% of cases are you going to diagnose the cause of syncope on an EKG. But a lot of them, you can increase your suspicion if they have some findings, like QRS widening, bivesicular block, things like that. So if you are concerned for arrhythmogenic syncope, especially with that drop syncope, like you were saying, inpatient and also outpatient cardiac monitoring. And then anyone really with cardiac syncope, or even older patients with syncope of unclear etiology, you really do want to get a TTA. So TTA really in all patients, either if it's, unclear etiology, or if you have any, obviously if you have any presence of these red flag features. All right. So he gets a TTA. This was a case actually given to me by Raj from Cooper. He went here last year. And this is his echo. I'll keep playing this. Anyone see any abnormalities with this? And I'll just, so this is your LV, and this is your RV here. Oh, I think someone got it. Yes, this is arrhythmogenic ventricular cardiomyopathy, ARVC. So, or dysplasia. I've seen ARVD and ARVC. So Candace got it. That's exactly what it is. And this is what this patient had. So ARVC, what it actually is basically fibro-fatty replacement of the patient's myocardium, specifically in the right ventricle. You can kind of see this fat displacement here that really sets up as a vector or a foci of the patient getting ventricular arrhythmias. So you may see on an echo that RV is like fibro-fatty replaced. It might dilate, it may be dyskinetic. You may see that on an MRI too. So here's your RV right here. And you can see just how dysplastic this RV is from that fibro-fatty infiltration. And also, RV is not supposed to be bigger than the LV, which it is here. So that is always, anytime you see that on echo, is concerning. Further workup for these patients. I like this one because you do kind of throw the whole entire, workup for cardiac workup to these patients. You do a TTE. You want to do a MRI. You want to do a cardiac MRI for these patients. And a lot of them actually get an EP study. And the reason why they do that is they want to find the focus of VTAC in the RV. And they kind of do this by basically putting like low amplitude like testing around the RV and then trying to find a spot with low voltage. And that spot may be actually the foci of VTAC, and then they ablate it. So it's diagnostic, and it can also be treat. It'll also treat as well. So that's kind of the kitchen sink for the further workup you can do for cardiac arrhythmia. Every patient EKG, all patients TTE. If they have drop syncope, or if they have like syncope while sitting down, or if they have any of those like palpitations, things like that, you're going to want to do outpatient cardiac monitoring, and then an EP study for really high risk patients where you think, if you don't do something, they could end up, dying from this. And the EP study that the patient got, since they had weekly symptoms, is going to be an external loop monitor. So this is you might get tested that, daily symptoms, you can do a Holter, because it's only on for about 24 to 48 hours. A loop monitor you can wear for about a month. So if they have weekly symptoms, it can help. And then if they have monthly symptoms, you're not going to catch them with either of these. So you got to implant something into their body that's going to record that heart for over a long period of time. All right, and then back to the case. Do we have anything that happened with the case? I think we're running.
Nick, can I ask a quick question?
Yeah, of course. What's going on?
Can you just go through the EKG with us on the third case?
Oh, yes, of course. Thank you. I forgot about that. Yeah, so ARVC, the typical finding is this epsilon wave. So it is this little kind of spike right here, right after that QRS complex. And this is concerning for basically loci in the RV, because remember it's in V1 and V2, a loci that has kind of delayed polarization, so delayed repolarization. It creates this pretty weird epsilon wave. So that's something that may help you on an EKG, but unfortunately this is only present about 1/3 of cases. Like a PE, these patients have these patients have RV dysfunction, right? They have fibrodysplastic replacement of their RV. So actually the more sensitive finding in about 95% of these patients is actually just going to be T wave inversion in V1 and V2. So those are things that can help you when thinking about ARVC. Also, obviously, a history of, palpitations, syncope, and it may be more likely in younger patients, but I have seen there was a patient that was older that had it too. All right, and then I think the case didn't really have much of an outcome.
No, she was discharged from the ED.
So
Discharged.
She's discharged. She did get she got carotid ultrasounds as well, just given her history of like fulminant history of vessel risk factors, but she had minor plaques.
Okay.
Otherwise, the telly was uneventful for 24 hours.
Okay.
And they basically decided to send her home with outpatient follow-up for Holter monitoring.
And then TTE was unchanged as well, from my understanding.
Yes.
Okay. So she got that TTE. That was, I mean, this is a lady that, you know, this does sound like maybe she's taking her medications wrong. She gets a little bit of low blood pressure, she gets a vasoplegia by going in the shower, and then she passes out. But she's got a ton of comorbidities, and we weren't in this category, right? Because it wasn't there was some red flags with her old age comorbidities, and we didn't have a clear etiology. So she goes back pretty much into this area, and then we really, once you get to here, in all patients, you really need to at least do a TTA. And the fact that I think she had drop syncope, in those cases, you know, outpatient cardiac monitoring. But she didn't need to be in the hospital for too long once you get this kind of stuff. Sonia says discharge Jill. So she was discharged, and that is the end of the case. This is a little thing that I'll put this, if you guys want this little algorithm, I'll put it on the slide set that we send out, that I put on the email every week. But thanks for joining, everybody.